The Pentagon just announced it's testing every service member over 30 for testosterone. Sounds simple. It isn't. I am Dr. Harvey Jenkins, MD, PhD, retired orthopedic spine surgeon, pain management physician, and biochemist. Here's the policy. Troops 30 and up get annual testosterone screening as part of their regular health exam. Under 30, it's optional. If you're flagged as deficient, treatment is your choice, not a requirement. And there's a real case for it. Special ops troops in particular deal with sleep deprivation, brutal training loads, and calorie deficits that can genuinely suppress hormone levels. That's a known, documented problem. But here's the science problem. Testosterone swings all day. Diagnosing deficiency properly needs 2 separate early morning blood draws plus actual symptoms. A single test on a tired, stressed 32-year-old isn't a diagnosis. It's a snapshot. And we already know overtreatment is a problem. Up to a third of men on testosterone therapy in the U.S. don't actually meet the medical criteria for it. Now add a military culture that ties testosterone to lethality. That's a real pressure, even when treatment is technically voluntary. What about risk? The old fear that testosterone therapy causes prostate cancer has softened with newer trial data. But TRT can accelerate an existing undiagnosed cancer, and it raises real risks for blood clots and atrial fibrillation. None of that is zero. There's also an age problem. Military ranks span 20s to late 50s. A 32-year-old's low reading might just be training stress. A 55-year-old's might be normal aging. Treating both the same way isn't good medicine. This isn't a story about whether testosterone therapy works. It does, for the men who actually need it. It's a story about what happens when population-wide screening outruns the evidence for population-wide treatment. It is also a story about letting a cultural narrative about lethality for the Department of War dictate health policy on our troops and service members. Testosterone supplementation on the wrong candidates can lead downstream to increases in thromboembolic or blood clot events, erythrocytosis or elevation in red blood cell counts, suppression of fertility, sleep apnea, and have a potential impact on prostate cancer. If we don't pair this with rigorous screening and real long-term tracking, we won't see the cost for years. A cancer signal, if there is one, shows up in a retrospective study a decade from now, not in a headline today. Stay curious. Stay informed.